Thank you for inviting me for this program. Today, I'll be presenting our study titled Gender Disparities in Patterns and Outcomes of Substance Use Disorders. Substance use disorders are major public health problems. It contributes significantly to morbidity and disability occasioned by psychiatric comorbidity. There is a high burden in low and middle income countries due to limited access and treatment gaps. Gender influences patterns, presentation, and outcome. Despite this, despite the availability of data from the advanced countries, there's a limited independent data from sub-Saharan Africa, especially among the inpatient settings. So this study, we examined gender differences in patterns of substance use, psychiatric comorbidity, treatment outcomes, and we also look for predictors of relapse within 6 months. So we conducted a retrospective study covering 6 years in Department of Psychiatry, Federal Neuropsychiatric Federal Medical Center, Umaya, from 2018 to 2024. So we examined the folder of 286 psychiatric inpatients that was diagnosed using that fulfill the criteria for substance use disorder using ICD-10 diagnosis. So we use chi-square for categorical variables, t-test for continuous variables, and then logistic regression to determine relapse, independent predictors of relapse within 6 months. And the signal value was set at p less than 0.05. So of the 286 patients, 70% of them were males and about 30% were female. So there was marked male predominance. This may be explained by the likelihood of males, likelihood of engaging in riskier behaviors, and then sensitivity and reward sensitivity that is commonly found among males. So when we look at the substance use patterns, there are males predominantly use cannabis, and opioid use, the disorder predominate among females. And this was statistically significant with chi-square of 105.64 and p-value less than 0.001. So polysubstance use were also higher, significantly higher in males than female. The chi-square of 4.95 and p-value less than 0.001. Also, when we examine the duration of use, males were the average duration before presenting in the hospitals was 6.81 with variability of 5.04 years, compared to females of 3.33 with variability of 2.90 years. This relationship is also significant with t-value of 4.99 and p-value less than 0.001. And our longer exposure among males than females. The shorter exposure before presentations can also validate the telescoping effect among females. The rapid development of dependence after the initiation of substance use. Also, the psychiatric comorbidity, the overall was higher in male than female. Males are 68%, while female is about 22%. Chi-square is 53.363 and p-value less than 0.001. The patterns of the diagnosis also varies. Males tend to have psychotic disorders, while female has anxiety disorder. This also suggests the variability in the expression of psychopathologies. Males are likely to express uh, uh, so on length of stay, males also females stay longer than the female. And this is also statistically significant. The t-value minus 7.16 and p-value less than 0.001. So when we look at relapse within 6 months, males are more likely to relapse than females within 6 months. And this relationship is also statistically significant with chi-square of 52.92 and then p-value of less than 0.001. So we are examining these discharge outcomes. Males were likely to discharge against medical advice, which shows that there were higher clinical engagement and clinical improvement in females. So, using the logistic regression to look at predictors of relapse, male gender were 11 times more likely to relapse than female. So the integrated pattern, males had longer use, more polysubstance, more psychotic comorbidity, and higher discharge against medical advice and relapse. This connotes higher risk clinical trajectory. So what are the clinical implications? There should be gender-responsive care, integrated treatment that address both the substance use disorder and the psychiatric comorbidity. We also need to strengthen discharge planning, especially for males. Then improve continuity of care to reduce the high level of relapse among males. So these our findings should be interpreted cautiously. It was a retrospective design. We could not be able to accommodate measure some of the factors that could be responsible for the high level of relapse among females. It was conducted in a single center, though it could be generalized to centers with similar settings. And also the findings also aligns with international findings, which means that the study, what we found, has also some external validity. Then the diagnostic, we use a clinical-based diagnosis by consultant using ICD-10. No validated instrument was also used to assess the diagnosis. This could also affect the, but this one can enhance the ecological value of the what, but it can also affect the generalization of the study. And then there are possible residual confounding, even when we look at the statistics, it shows that the gender, though the male gender, though is an independent predictor of relapse within 6 months, It also shows that it might just be serving as a proxy. There might be some unmeasured factors which is also responsible for relapse. Relapse is not only clinical, it will also be partly structural. There is a need for gender responsive care. Thank you for your attention.